Good evening, everybody, and welcome all of you to the live program number 160 at Orthopedic Principles. We are back with our amazing faculty, Dr. Kshitij Chaudhary from Sir H.N. Reliance Hospital, Mumbai. After completing his residency in the prestigious KEM Hospital, Mumbai, Dr. Chaudhary completed a Twin Cities Spine Fellowship at the Twin Cities Spine Center, Minneapolis, Minnesota. And subsequently, he joined as a consultant spine surgeon at Sir H.N. Reliance Hospital, Mumbai. Dr. Kshitij has been doing exceptional work in spine and spine deformities. And today, it's my great honor to bring back Dr. Kshitij Chaudhary for this wonderful live program on scoliosis, how to do a clinical and radiological work. Over to you, Kshitij.
Thank you, Dr. Hitesh, for that kind introduction. And actually, this is the second part of our spine examination talk. And a few months ago, we had done a general spine examination lecture. And there were a lot of questions last time about how to go about doing a scoliosis clinical examination and a radiological workup. So this talk is going to be about scoliosis, and there's going to be some overlap. As far as possible, I have tried to separate out the two talks, and for those who want to refer to that previous talk, it's there on the Orthopedic Principles channel. So to begin with, one of the main concepts of scoliosis is the definition. And by definition, a scoliosis is a lateral deviation in the spine of more than 10 degrees. So in a coronal plane, the spine is straight, and a deviation from that more than 10 degrees is defined as scoliosis. But that's not the case for the sagittal profile, because as you know, in the sagittal profile, the spine is an S-shaped curve, and there is no fixed value what is determined as normal. So a kyphosis in the thoracic spine is a range, as well as lumbar spine lordosis also is a range between 40 to 60 degree. So there is not one single cutoff value, and the sagittal profile varies widely between normal people, but that's the difference between the sagittal and the coronal plane. So with that key concept, we go on to scoliosis. However, scoliosis is not a diagnosis. Scoliosis is can be caused by many etiologies. You can see here, this patient has idiopathic scoliosis. This patient has congenital scoliosis. This is a neuromuscular curve. This patient has neurofibromatosis. This is idiopathic. This is congenital with a split cord malformation. This child again is congenital, and this is a child that is syndromic, and we don't exactly know, but this is a non-idiopathic curve, but we don't know the name of the syndrome. So the message from this slide is that scoliosis per se is a big variety of patients, and all these patients will behave differently. And that's why it's very important in your history and examination to try to find out what is the exact etiology of this of a scoliosis patient. And that can be done with history examination, your imaging findings, x-rays, sometimes MRIs, and sometimes you need specialist referrals to pediatricians and geneticists if you are looking at some syndromes. Apart from this, you are also looking at the skeletal maturity of the child, because this plays an important role in the management of the patient. And skeletal maturity is assessed using clinical markers and some skeletal markers that we will go through later. The third aspect are the x-rays, and the x-rays determine how severe the curve or the curve angle is. And if you take all these three characteristics of the curve together, these three characteristics decide what the natural history of that scoliosis is going to be. And what I mean by natural history is how this curve is going to progress as the child is going to grow. And this is an important thing to know because that determines what you are going to do with the patient. So as a treatment option, any scoliosis patient, there are four options available. Either you do nothing and send the patient home and say that, okay, I don't want to see you again, and this thing is not a problem. Second is you're going to keep the patient in observation. That means you're going to say that, okay, I'm not sure what is going to happen to this curve. Come back in 6 months, we'll review again. And that's called observation. The third option is bracing, and the fourth option is surgery. So apart from these four options, there is nothing really else you can do for scoliosis patients. So to determine what option you are going to choose, you need to have a good understanding of the natural history of that curve. And for natural history, you need to know these three aspects of a scoliosis patient. So we are going to take these three aspects separately, and this talk is divided into three parts, but we'll start with the skeletal maturity first. To begin with, I want to say that idiopathic scoliosis, which is the most common type of scoliosis, is a diagnosis of exclusion, which means that your history, examination, x-rays, and all the investigations you are doing to exclude a diagnosis of all the other etiologies. And if everything else is excluded, then only the scoliosis gets labeled as idiopathic. So the first part of the talk is about growth, maturity, and the skeletal maturity. And this is a very important concept. Without understanding this, you really cannot examine or take a history properly of a child. So if you see in this chart, a kid has a very rapid growth in the intrauterine period. And as the child is born, this very rapid growth, although it is falling in the first 5 years, it is quite fast, as you can see. So in the first 5 years is the first growth spurt of the child. You can call it a growth spurt, but it is actually a decreasing speed of growth, but still it is quite fast. After about 5 years of age, the growth kind of slows down and plateaus off. And somewhere at this point, girls hit puberty earlier than boys. And when they hit puberty, they start growing faster, hit a peak, and then start slowing down again. Boys start puberty a little bit later, about 2 years later. They peak also later, but higher, and they keep on growing for a longer period of time. And that's how in a certain age group, somewhere between 11 and 13, in a classroom, girls are taller than boys. But in the end, when you are in the 9th standard and 10th standard, you'll find that the boys in the class are taller than the girls. And boys grow for a longer period of time than girls, have a higher peak, and that's why they end up being taller than girls. Although to start with, girls have they hit puberty earlier than boys. So that's a basic concept, and many of you will know that. So what is important to know, what is the relationship of this growth curve with the scoliosis progression? So in this chart, this is a very famous study done by a French surgeon, Dr. Duval. And what she did was she plotted the cob angles of different curves and plotted them against the growth maturity curve. And you can see that this line is the cob angle progression as the child is getting older, and this line x-axis is the age. So you can see that the cob angle suddenly starts increasing at this point, which is defined as P, and this corresponds to the first signs of puberty on this growth maturity curve. You can see that the P point corresponds to where the height starts increasing in a child at the time of puberty. So this is a very important concept in scoliosis. So whenever you are looking at a patient, you are trying to find out where the patient is in this growth maturity curve, at which stage is the child in, so that you can predict what is going to happen to this curve as the child goes through puberty. So the whole idea of this skeletal maturity thing is to how to identify this point P if you are seeing a child that is immature. Another important concept to know that all children will not hit that puberty at the same age. So there are children who are going to be early bloomers, and there are some children that are going to be late bloomers. So you cannot have a fixed age of puberty as you have experienced in your practice. So this is a chart that it has plotted the speed of growth during puberty in 5 children, and then you can see child 1 has a puberty earlier at a younger age, and then child 5 is having it at a later date. And you can also notice that the children who have hit an earlier puberty have a higher peak or speed of growth versus the children who have a later onset of puberty. But this graph is important to understand that different children will have their growth spurts at different time. And if you average out these growths, you are going to get a growth curve like this, which is not very useful in clinical practice because this is a very smooth kind of curve and does not have any peak. So a more useful growth chart is plotting the x-axis with respect to years from the peak growth velocity. So if you take peak growth velocity and combine all the 5 curves, you will get a curve that looks more sharp like a mountain peak. And then you have these years that are -1, -2 from peak velocity, and +1, +2, +3 from peak velocity. And this is how the growth height is going to change. Change in centimeter per year of a child is going to follow this kind of a pattern. The only problem is that it is not going to be at a fixed point in time for every child. And that's brings us to this important concept that the chronological age of a child cannot be the only parameter of choosing or deciding the skeletal maturity of the patient. What is more important is the skeletal age of the child. And here is an example. If you are a surgeon looking at the x-ray and counting only the age, you will say that this girl is only 13-year-old, and so we know that she's going to get worse, and so we are going to do surgery. But this surgeon is not noticing that this girl almost is looking like a woman and has all the secondary sexual characters. So even though she is only 13, she has passed through most of her growth spurt, and this would be a wrong thing to do to say that she's going to get worse. And the other way around, if you look at this girl and say that this is 15-year-old child and she's too old for a brace, and this x-ray is going to require surgery because she's not fit to undergo a brace, then you will be making a mistake, because you can see that this child does not have much of secondary sexual characters and still has to go through growth spurt. So you can potentially brace these scoliosis patients if they still have a lot of growth pending. So that's a concept that we'll have to remember, that you cannot just rely on the chronological age of a child. So that's the reason for knowing the menarche, the secondary sexual characters, some of the radiographic signs, which are the Reiser sign and the triradiate cartilage. And then if you have a serial follow-up of the patient, then height measurements of the child are extremely important to understand how the growth of the child is progressing. So every single parameter that these clinical and radiological parameters, you need to know where these parameters lie on the growth curve. So here, this is the growth curve only of the puberty of a girl child, and this is of a boy. So you can see that girls start the puberty at 11, boys about 2 years later at 13. And mind you, these are all skeletal age rather than chronological age. The peak height velocity is reached at 13 for girls and 15 for boys, and by 16 girls have stopped growing and boys have stopped growing by 18. So here, if you'll see, this chart is about the Tanner's grade, and you can see the corresponding thing about the start of puberty corresponds to the Tanner 2 stage. So the Tanner 2 corresponds to this point for girls, and the Tanner 2 corresponds to the start of puberty in boys. So to simplify that chart, this is all that you have to remember. all you have to remember is Tanner 2. There is no point remembering all the Tanner stages. So the most important Tanner stage is Tanner 2, which is the appearance of breasts in girls and pubic hair. And in males, it is appearance of pubic hair. So that is Tanner 2. So the Tanner 2 signifies the absolute start of puberty. The triradiate cartilage closes somewhere in the midpoint of this upslope of the growth. At the peak, there is closure of the olecranon physis. On the downslope, somewhere about 6 months from the peak height velocity, is the onset of menarche or the onset of axillary hair in boys, and that corresponds to the Reaser 1 radiographic marker. So these points are important, and these happen approximately 6 months from the peak height velocity that is reached. And then Reaser 4, or when there is no change in serial height, that's the time when the growth has stopped, right? So as I said, important thing to know is Tanner 2 staging. If you find a girl has a breast budding or appearance of pubic hair, you know that she's already in puberty, because Tanner 2, appearance of Tanner 2 is all of the indicates that the girl already is in puberty. Whereas in boys, appearance of pubic hair, which is equivalent to Tanner 2, means that the boy is going to go into puberty and it is just around the corner. So those are important aspects. The other thing about menarche I wanted to tell you is that after menarche, the growth in a girl approximately goes on for about 2 years of 2 years. So you can expect somebody who has had menarche to continue to grow in height for about 2 years, during which the curve can progress. Although you notice that menarche happens after the maximum speed of growth already is over, so the growth is slowing down, which also means that the rapidity in which the curve is going to progress also is going to slow down. So menarche is not such a useful marker in a very immature child, because it happens so much later than the fastest growth. So once you know that a child has menarche, majority part of the growth, or the majority of rapidity in which the child is growing already is in the past. So that's one important concept to remember about menarche. And here is this chart that shows that the plateau period that I told you, between the 5 years until the onset of puberty, the rate of growth is about, height is about 5.5 centimeters per year. So if you are following a scoliosis child and the growth is more than half a centimeter a month, which is more than 3 centimeter in 6 months, you can say that the child is in growth spurt, because then the child is somewhere in this region of the growth velocity curve. So if the child is growing less than half a centimeter a month, then the child is in this part of the growth spurt. So this you will know only if you are doing serial height measurements, which is an important thing to do if you are serially following some scoliosis patients in your practice. So then coming to the second part of the talk is the history and examination. So in the history, you are asking for some chief complaints that a patient with scoliosis might present with. And these are the five main complaints a patient may have. Most important is the cosmetic issue or the deformity, which either the child may notice herself or himself in the mirror, or a parent may notice, or a pediatrician may notice it. It might cause some psychological concerns in, especially in teenage girls, who might notice that their shoulder is off balance and they have a rib prominence and their clothes don't fit them properly. So these will be genuine concerns that a child or a family may present with. So it's important to ask, when was the deformity noticed first, and who noted it, because a pediatrician probably is going to notice it very early, whereas parents and the child may notice it much later. And the time is important, because if the onset of deformity is say the deformity was present at birth, that indicates that it could be a congenital curve. If the deformity was present say started at 8 years of age or 9 years of age, it could be a juvenile idiopathic scoliosis. And the reason why this is important is that the curves that start in less than 10 years of age have a higher incidence of having something abnormal with their spinal cord. uh, Means the younger the child, the more likely that you are going to ask for an MRI. The third question you'll ask is whether the curve is progressive, and if the parents say that yeah, within 6 months this has gone really really bad, and it was not even noticeable 6 months ago, then the more rapid the progression of the curve, the more likely that the curve could be non-idiopathic or may have some neurological abnormality. And the fourth question is what have the family or the child taken treatment for this till now. It could be maybe brace or maybe something else that has been done for the child already. So you need to ask about what treatment that they have taken for this deformity up till now. The second symptom could be pain, and normally idiopathic scoliosis does not cause pain. So if a child has a deformity and presents with pain, then you are suspecting non-idiopathic causes. Like this patient has a scoliosis and has a spondylolisthesis and a lytic spondylolisthesis, and this child has a scoliosis because of an osteoid osteoma. So there are many reasons for having pain associated with scoliosis, and the one of the more sinister causes of pain is a neuraxis abnormality such as a tethered cord or a syrinx, and a patient who is complaining of pain at rest when disturbing sleep, and a non-mechanical sort of pain. That patient, especially if the curve pattern is atypical, then we are going to ask for MRI. So that's the second symptom. The third symptom could be some neurologic symptoms, and broadly they could be of two types. One is because of a deformity, and this usually happens in angular kyphosis, and it's uncommon to happen in idiopathic scoliosis or just a pure scoliosis patient. So it is more likely to happen with congenital kyphoscoliosis or neurofibromatosis, or those children who have a very sharp angular curve, and they present with some gait problems, spastic gait, and loss of balance. But also important to identify that neurologic symptoms could also be because of some underlying neurological causes like Chiari malformation. Like Chiari malformations can cause headache, neck pain, numbness in the hands, paresthesias in the hands. Sometimes syrinx can cause neurological abnormalities. So having neurologic abnormalities doesn't necessarily mean that the deformity is causing the spinal cord compression. It could also be neurological symptoms because of diastomatomyelia, syrinx, tethered cord, or Chiari malformation. So you can see this child is walking with a very spastic gait, and this patient has had a congenital kyphoscoliosis because of a posterolateral hemivertebra that was causing compression on the spinal cord. The fourth point is cardiopulmonary problems, and these usually happen in children that have very severe neglected deformities, like this child who has a 125-degree curve. So typically curves more than 80 degrees or 100 degrees would cause some restrictive pulmonary function that can cause the child to complain of breathlessness. They are not able to keep up with their peers when they are running or climbing stairs. They have to stop. They feel short of breath. So these are the problems that are associated with very severe curves. Then coming to the second part of history is the birth history. Now it's very important to start with the birth right from conception. So you want to ask about the parents. Did they have a consanguinity of marriage? Did they marry? Did they marry within relations? Because if they marry within relation, then the chances of having some genetic abnormalities are much higher. So that is important point not to miss. Whether there were any issues in pregnancy, what about the health of the mother? Did the mother seek any antenatal care? Was it appropriate? Was the mother diabetic? Did the mother take those proper vitamins and nutrition? Did the mother have any previous pregnancies that ended with miscarriages? So all these are important because the health of the mother can have an effect on the type of scoliosis as well. And you most importantly, you want to identify were there any issues during the birth, during the perinatal period and the postnatal period. what kind of delivery was it? Was it a home delivery? Was it in a hospital? Was it at term, or was it premature? Was it a C-section, or was it vaginal delivery? If it was vaginal delivery, was the delivery prolonged and difficult? Did the child require post-op ICU, ventilatory care? Did the child develop jaundice? So all sorts of things that could affect the outcome of the pregnancy are important, because many children who have insults to the brain and the neuraxis during this time can develop scoliosis. And one typical example of such a problem is cerebral palsy related scoliosis. The next is developmental history. You want to know the motor milestones, when the child started walking. All these milestones that the child achieved, were they at the right time or they were delayed? Did the child have any learning disabilities? When did the child start speaking? How is the child's communicative abilities right now? What is the child's grade in school? Is that grade appropriate for the age? Is the child lagging back in school? Can the child keep up with the peers? Is there any signs of mental retardation and things like that? So these are again pointers towards a non-idiopathic cause of scoliosis. So these are important things to probe. And then on history for the skeletal maturity, you are asked, if it's a girl child, you are asking for if there is menarche, then what was the age at which the child achieved menarche? And you want to record this menarche in years and months. So like, let's say the child achieved menarche at 11 years and 6 months, then you want to say that it is 11 plus 6 years. That's the time that the child achieved menarche, rather than just saying 11 years, because there is 12 months gap between 11 years and 12 years. So you want to be specific, because you are now counting from that point for the next 2 years to determine that, okay, this child is going to grow for the next 2 years from the onset of menarche. If the child is pre-menarchal, then you may ask for the mother, or if she has an elder sister, approximately when they had menarche, because it is genetic. Many kids would have more or less the same age at which their mothers achieved menarche. So if it is a really important issue for you to decide when to call this patient back for a next follow-up, because the growth spurt is right around somewhere in the corner, so you will have some idea if you ask about mother's menarche as well. But these are finer points. But most importantly, you want to know what is the age at which the child achieved menarche, or is the child pre-menarchal. You may ask for shoe size, and whether there is a very rapid change in shoe size or change in the clothes of the child. So the foot size is the first thing that starts growing when the child hits puberty. So if you elicit that history that, okay, we have to change this our kids shoes every few months, then you may note that the child no longer is in that plateau phase, but it is now in the puberty phase of the growth maturity curve. And towards the end of growth in boys, especially if they are shaving regularly, or they need to shave regularly, then that indicates that they no longer are going to grow any further. So that indicates the end of growth. It's important to ask for family history. As you know, some of the scoliosis may run in families. AIS has an incidence about 7% in siblings. So if you have one sibling who has AIS, the chance of having a second sibling with AIS is about 7%. And that number increases if the parent is also having that deformity. Neurofibromatosis is autosomal dominant. So you want to ask, if you suspect neurofibromatosis, whether the parents have any lesions. And if the parents or the siblings are in the room with the child, then you want to do a quick Adams forward bending test for the parent or the child's sibling, to quickly know whether they have scoliosis, because many of them may not know that they have scoliosis. So that you can easily examine the parent by immediately doing a Adams forward bending test. So the last part is the past medical history or surgical history, and these might give you clues about the etiology of the curve, like say hearing problems and visual problems. Hearing problems may be in clipple file, usual visual problems may be in Marfan's, cleft lip, cleft palate can be in congenital scoliosis, so can tracheoesophageal fistulas and Vactral syndromes and cardiac anomalies and surgeries for some genitourinary abnormalities. So if the child has had some surgery for a for the spine, for releasing the tethered cord, or some closure of the anal, or opening up of the imperforate anus, so all these things are clues to say that okay, this curve is could not is possibly not idiopathic, and there is some underlying cause for this and could be congenital. So it's important to take a very detailed past medical and surgical history. So that brings us to physical examination. And as we discussed last time, the physical examination is divided into three parts: the spine examination, head to toe examination, and neurological examination. And this is the equipment that you need to do a spinal deformity exam. You need a measuring tape, you need a 6-inch ruler, and you notice that this 6-inch ruler is starting from zero. It does not have a gap between the zero and the edge of the ruler. You need a carpenter's plumb line, and the scoliometer is optional, especially for the students that are giving MS exams or DNB exams. You don't have to carry a scoliometer with you, but these three things are mandatory if for a deformity patient. But if you are interested, you can use the scoliometer in your phone. So every phone nowadays, the smartphones have an inclinometer in it, and in iPhone the free app is the measure app, where you can use the iPhone on the back of the patient to do the scoliometer readings on the Adams forward bending test. But obviously in an exam you are not going to be allowed to carry your phone inside. But if you are in your OPD and seeing patients, then you can quickly do scoliometer readings with your phone, right? And physical examination is extremely important because it's not only an X-ray disease, as John Dubusset says, and no patient walks around with an X-ray pinned to his or her back. And it's a very bad habit to look at a spinal deformity patient and directly jump to the X-ray, because the physical examination gives a lot of clues, and also helps sometimes in deciding the management of the patient. So physical examination should be very, very detailed in a deformity patient. So there are these four categories, and we discussed these last time as well. But I just want to point out the differences between what it is from the last time. In the inspection part, you are looking at signs of sexual maturity. In the range of motion, you want to look at the flexibility of the curve as you move the patient. In the palpation part, you are going to palpate for the spinous processes, which will tell you how the curve is, because palpating the spinous processes will tell you the thoracic part of the curve and the lumbar part of the curve. And for the measurements, important measurements are the height, which is used to determine serial height measurements, for understanding the rate of growth of a child. And you may also do arm span measurements and other measurements like that. But these will be the most key points in a deformity patient. So a posture of a normal person is erect. The head is centered over the pelvis. Ear, shoulder, ankle are in straight line. We discussed this all in the last lecture. I won't go into it, but a very severe deformity is going to alter the patient's posture. Adolescent idiopathic scoliosis may not alter the posture, but usually the most typical varieties. But if it's a very severe deformity, as you can see in this patient, the posture is changed so much. The shoulders are unequal, the trunk is not balanced, the pelvis is oblique, and that is causing an apparent limb length shortening, due to which the child is standing with an equinus. So a lot of abnormalities may be seen, postural abnormalities, if the curve is very severe. More important is the spinal alignment. And as we discussed in the first slide, the normal spinal alignment in the coronal plane is straight. So if there is any deviation from a straight alignment, that is called as scoliosis. But it is important to remember that scoliosis is a three-dimensional deformity. So it is not only in the coronal plane, but it is also in the sagittal plane, and it is also in the axial plane. So so this is more tricky assessment, and it is important to concentrate. It is important not to concentrate only on the coronal plane. You need to look at the axial plane and the sagittal plane as well. So three things you will have to look in spinal alignment. The first obvious part is the curves, and the curves are defined by their apex, where the apex of the deformity is. If the apex is in the thoracic region, it is called as a thoracic scoliosis. If the apex is thoracolumbar, means T12, T11, T12, then it is, sorry, T12, L1, then it is called thoracolumbar scoliosis. And if the apex is in the lumbar part of the spine, then it is called lumbar scoliosis. The side of the curve, whether it is a right-sided thoracic scoliosis or left side, is decided by its convexity. The largest curve is called the major curve. So if the thoracic part of the curve is the largest curve, then you are going to call it as a right-sided thoracic major scoliosis. And that typically is if it is a C-shaped curve. But if there are two equal curves on opposite side, or the curvature of the spine is the shape of S, then it is called as a double major curve pattern, that there are two big curves and the shape of the spine is in that of a S rather than that of a C, right? So the second part is how the scoliosis is affecting the symmetry of the back. Now the scoliosis may cause a malalignment of the shoulders, one shoulder being higher than the other. The rotational deformity will cause a rib prominence if it is the scoliosis in the thoracic spine, and it may cause a lumbar prominence if the scoliosis is in the lumbar spine. It may cause a waist asymmetry. It may have arms that are unequal from the sides, or can cause pelvic obliquity. The moment you have pelvic obliquity, remember to do a limb length discrepancy examination and hip examination, because pelvic obliquity can also be because of these other factors outside the spine. And the third aspect is the balance, and there are two types of balance: the head and the trunk. So how do you go about doing this? And many people are confused about how to speak about a scoliosis exam. Uh, a scoliosis exam, when you are presenting, it is better to say it in terms of, examining from the back, front, and side, rather than categorizing it as inspection, palpation, and movement, look, feel, and move, because it's very difficult to categorize a scoliosis exam like that. So inspection and palpation usually is together in scoliosis, and the best way to go about is to say that, as examining the patient from the back, my inspectory and palpatory findings are such and such. So that's the way we are going to go about seeing this. So first is, as examining the patient from the back, what you are going to look for is the shoulder level, the curves that we discussed, and the curves are described by the apex of the curve, the curvature that is on the right side or the left side, and whether it is a C-shaped curve pattern or an S-shaped curve pattern. What is happening to the rib prominence? Is there a flank crease, like this patient has a flank crease here? How is the pelvis, whether it is oblique or straight? And the balance, whether there is a head balanced over the pelvis or not. Or trunk decompensation, whether the trunk is balanced over the pelvis or not. Any tender points, the range of motion, and skin. Sometimes they have neurocutaneous markers that are very obvious when you look at the patient from the back. So to split this, the first part is the curve. As I said before, it is the location of the curve that is determined by the apex. This child has an apex that is in the thoracic spine, so she has a right-sided thoracic scoliosis, and that's the major part of the curve. And this is a C-shaped curve pattern. So if you palpate all the spinous processes here, you will be able to find out that this is a C pattern curve, whereas this patient has a S-shaped curve pattern. You can notice that. So that there are two curves here. There is a right-sided thoracic scoliosis and a left-sided lumbar scoliosis, and both appear to be quite large, and that's why this is a double major curve pattern. So that you can identify that by palpating the spinous process. Now, how is the scoliosis affecting the symmetry? Here you can see the shoulders are pretty much level. Here also they are level. In this patient, the right-sided shoulder is higher. You can see rib prominence here, scapular prominence because of the rib prominence here. You can see the rib prominence on the right side. And this child has a very, very large rib prominence because of the severity of the curve. Uh, Asymmetric flank crease, this child does not have it, but this child has a flank crease that is asymmetrical, a much deeper curve here on the left side, and a much deeper crease here on the left side. Then if the child is standing with the arms by the side, you may notice that the distance from the trunk to the arm here is increased compared to the left side. And again, the pelvis level in this child is abnormal. For the balance, there are two types of balance. For the global balance, you want to drop a plumb line from the C7, and in a normal patient, it will fall in the natal cleft. So if it doesn't fall in the natal cleft, then you can say that the head is not centered over the pelvis. If the head is centered over the pelvis, the C7 plumb line is going to fall right bang in the middle. And there is another concept that you have to know is the trunk imbalance or the truncal decompensation, and that you determine by determining the midpoint of the thoracic cage or the rib cage. It's usually at the apex of the deformity, and then drop a plumb line there, and you'll notice that even though this patient's C7 plumb line falls in the middle, the trunk has shifted on the side, and the trunk is not centered over the pelvis. So here you can see the head, there is no head decompensation. C7 plumb line falls right in the middle, but the trunk is shifted on the side. So if you see the side of the rib cage, that is not exactly centered over the pelvis, and that causes a very cosmetic deformity that usually the children are not happy with. The next important thing to do is an Adams forward bending test, and the reason for doing the Adams forward bending test is to assess the rotational component of the deformity. And as we described before, that the deformity has three components: sagittal, coronal, and rotational. So the Adams forward bending test is for the rotational component of a scoliosis. The second reason for doing an Adams forward bending test is to see the sagittal profile of the patient. So you have to look it from the side to see what has happened to the thoracic kyphosis and the lumbar lordosis. So these are the two reasons for doing Adams forward bending test. Adams forward bending test is not to differentiate structural from functional scoliosis. That's not the reason for doing Adams forward bending test. It is primarily sometimes used as a screening tool because even mild curves can be picked up, which you may not notice when the child is standing. But the moment you ask the patient to bend forward, what happens is the anterior column of the spine is shortened when the child flexes. And if there is scoliosis, then the spine rotates out of the way to accommodate that shortening. And that's why the rotational component becomes more prominent, and you will be able to see the rib asymmetry much more clearly in this. Most people make a mistake of saying that forward bending test is used to determine structural versus functional scoliosis, but that's not true. It is a very early sign of scoliosis that is used as a screening test. So you want to look it from both sides. You want to have a rear view to look at the rotational deformity, that is the rib prominence, and you want to look from the side view also, that shows you the sagittal alignment of the spine. So this is the way you're doing forward bending test. You ask the patient to bend forward, the knees are straight and the trunk is parallel to the floor as much as possible, and you stand behind the patient and look tangentially and see how the asymmetry is. If you have a scoliometer, then you pass the scoliometer along the back. But it is important to know that these rotational deformities will be maximum at the apex of the deformities, and it is not only the thoracic prominence that you have to look, but you also have to look at the lumbar area, because if the child, like this child on the right, has two curves, an S-shaped curve pattern. The child has a thoracic scoliosis and a lumbar scoliosis. You will find in the thoracic area there is a rib prominence, and in the lumbar area there is a lumbar prominence, and that happens because the lumbar vertebra rotate, and the transverse process and the psoas muscle and the erector spinae become prominent on the convexity of the lumbar curve. So you get two prominences like that. So these are called ATR, or axial truncal rotation. So it's not just the lumbar prominence, but sorry, it's just not the rib prominence, but you're also looking at the lumbar prominence. And it is better to call it rib prominence rather than calling it a rib hump. Hump is not a correct terminology to use for it. So this child has only lumbar scoliosis, has no thoracic scoliosis. So you will see that in Adams forward bending test, the child does not have any rib prominence, but has a lumbar prominence like this. Now you also want to know what is the shape of that rib prominence. Sometimes very severe rib prominence are very sharply angulated, and some of them are smooth. And if you don't have a scoliometer, you can measure it like this. You can drop a plumb line over the rib prominence and make this limb horizontal and measure the distance from on the left side to this horizontal limb. That will give you approximate the height of the rib prominence. So this is a very approximation. This is not required to do in the exam, but if you don't have a scoliometer and if you are asked, then you can say that this is one way of measuring how severe the rib prominence is. But the best way to know it is using a scoliometer. So you can use it two ways. One is the angle, by placing the scoliometer on the back of the patient and noting the angle from this carpenter's tool, or you can keep the scoliometer horizontal, keeping this at 0. And if this is the midline spinous process, and if it is touching at say 5 centimeters here, then at 5 centimeters on the opposite side, take a scale and measure this depth. So then this becomes the height of the rib prominence, right? Then from the frontal view, you are looking at head tilt or torticollis, or the neckline if there is asymmetry, the level of shoulders, chest asymmetry or breast asymmetry in a girl child, rib prominence, how the pelvic anterior superior iliac spines are, if there is pelvic obliquity. You'll be able to see secondary sexual characters. If you ask the child to raise their arms up, you will see the axillary hair, and you can notice the skin as well from the front. This child has cafe au lait spots, as you can notice here. So from the side view, you essentially are looking at the sagittal profile. Most normal sagittal profile would be like this. The ear, shoulder, and all will be in same straight line. But you can see the regional alignment is lordotic, and that's a typical sagittal profile in an adolescent idiopathic curve. The thoracic spine is hypokyphotic or straight. In some kyphoscoliotic deformities, it will appear like this, and this child has a congenital kyphoscoliosis, and this child has such a severely rotated deformity that this is called as a kyphosing scoliosis rather than kyphoscoliosis. So this is the side view. You also notice how the child stands with respect to the hip and knee flexion. You can see that this child is flexing the knee and the hip and has an ankle equinus, whereas this child is also to balance himself so that he doesn't tip forward because of this kyphosis. He's flexing the hips and the knees. In supine position, primarily you are doing the neurological examination and sometimes limb length discrepancy. But this is also a trick for looking at breast development in a girl child without undressing the child. And if you keep the child in a supine position, and if you see any hint of breast, then you know that this child is in Tanner 2 or beyond, already in puberty and in the rapid growth phase of her growth maturity curve. In supine position, you want to do a neurological examination, and we have looked at this quite in detail in the previous talk. One important aspect that you want to see in scoliosis patients and not forget is the abdominal reflexes. Normally, abdominal reflexes could be absent on both sides, but if you have asymmetric reflexes, that means left versus right, you have present on one side, absent on others, that is clinically significant because that could happen in patients with neuraxis abnormalities and prompt you to ask for an MRI for a patient. In prone position, you can see what happens to the curve when the spine is unloaded, because some curves that are flexible might correct to a certain extent, or reduce in their severity when they are placed in prone position. You can do some flexibility tests in prone position. If the child has hyperkyphosis, then you can do an hyperextension test like a Bhujangasan, or do a push prone test in scoliosis. So flexibility assessment in standing position is just left and right lateral bending, and you want to keep your hand on the ribs that are connected to the apex and ask the child to bend on your hand to the opposite side and see how the curvature is changing. If the severity of the deformity is quite a lot, then, and if the child is small enough for you to pick up, then you can pick up the child by the ears like this to assess the deformity. But this is only possible if the child is small enough for you to pick. A better test is this push prone test sometimes in bigger children, where you are giving 3-point pressure on the curve to see the correctability. This hand is on those ribs that connect to the apex of the deformity. So you should not put the hand right at the most lateral part of the curve. You want to push on the ribs that connect to the apex of the deformity, and the ribs typically slant downwards. So you want to keep your hand a little bit lower than the apex of the deformity, so that you are pressing on the ribs that connect to the apex, and then you want to give a counter pressure on the pelvis on the other side to see how the curve corrects. And this is a prone hyperextension test to see the correctability of a hyperkyphosis. Now, the last part of examination is a head to toe examination. So we'll quickly go through this. We have seen that in the previous talk. So this is a Klippel-Feil syndrome, short neck, low hairline, pectus carinatum in a congenital scoliosis patient. This patient has Marfan syndrome, arachnodactyly, high arch palate, very wide arm span that is taller than the height, spidery thin arms and legs, ectopia lentis. This child has a dimple here, and this other child has a hairy patch here. And these are again signs of neuraxis abnormalities. This child had a tethered cord syndrome, whereas this child had a split cord malformation. This child has these small dots here. You can see these cafe au lait spots, which are indicative of neurofibromatosis. And this child has a big plexiform neurofibroma on the back and has a severe scoliosis. Then in the feet, you want to see asymmetry of the feet, cavus foot, intrinsic abnormalities, muscular weaknesses of the foot, claw toes, hammer toes, because all these can indicate problems in the spinal cord, such as those we discussed before. So very important to look at the feet of these kids. And limb length discrepancy is an important issue that you will need to examine in scoliosis patients, especially those patients who present with a pelvic obliquity. So a quick way to check limb length discrepancy is to make sure that the pelvis is square, and just look at the medial malleolus and see how they are with respect to each other. Within 1 centimeter of each other is normal variation between the legs, but if it is more than 2.5 centimeters, that is abnormal. And if you do find limb length discrepancy that is more than 2.5 centimeter, then your scoliosis examination has to be done with a raise. Because if you don't do your scoliosis examination with a raise, then the limb length discrepancy is contributing to the scoliosis as well, because the limb length discrepancy is causing the pelvic obliquity, which is causing the scoliosis. So that's something modification you will have to make if the limb length discrepancy is quite large. Beighton score, we have again seen last time. It can be present with patients with connective tissue disorders like Ehlers-Danlos syndrome, etc. And then when you are presenting your clinical diagnosis, you want to be brief and simple. So in a typical adolescent idiopathic scoliosis examination, you want to say that this is a 14 plus 6 or 14-year and 6-month-old girl who is 18 months post-menarchal with a right-sided thoracic scoliosis, probably adolescent idiopathic with truncal decompensation but without head decompensation. The curve is partially flexible and the child has normal neurology. So this covers the main parts of the curve, and you want to make sure that you say probably idiopathic scoliosis because you cannot say that for certain on a clinical examination alone, because if your x-ray shows abnormalities such as hemivertebras and all those things, then straight away the curve becomes a non-idiopathic curve pattern, right? So so that's about the clinical diagnosis. And then coming to the third part of the talk is the x-rays. Now mandatory x-rays that you are going to ask in a scoliosis patient are full length standing x-rays of the spine. You don't want very small regional x-rays. So these are typical 36-inch cassette x-rays or scanogram x-rays from top to bottom. And the first x-ray can be an AP x-ray, because an AP x-ray gives much more details of the bones. But an AP x-ray also means that there is more exposure to the breast and the genitals. So your follow-up x-rays are usually PA views. So in the exam, to avoid controversy, just say I will ask for a full length frontal x-rays. And if you are asked frontal PA or AP view, then you can say, if the first time I'm doing an x-ray, I'll ask for an AP view. But if they are follow-up x-rays, then I'll ask for a PA view. And you see that in the x-ray, you want to see the full width of the rib cage, and you don't want the x-ray to be cropped up like this from the side. You want to know where the C7 is. You want to clearly visualize the acromion and the clavicles, because that tells you the shoulders. You want to clearly see the pelvis, the iliac crest, because that's where the Reser sign is. And you want to see the triradiate cartilage here. Now, for the first time, this is okay, but all subsequent x-rays, you might want to put some guards here. Like this patient has a x-ray cassette reversed in front of the pelvis to reduce the radiation exposure to the ovaries, right? But such kind of an x-ray will not be useful as your first x-ray, because then you wouldn't know what is happening to the triradiate cartilage in this patient. So subsequent x-rays you can use breast shields and gonadal shields, but your first x-ray probably is without all these. And this is important because scoliosis children are going to get x-rays done multiple times during their childhood, and it has been shown that they stand at a higher risk for developing breast cancers and other cancers in their adult life. So you want to minimize the x-rays and make sure that your x-rays are perfect, and you are not repeating the x-rays because they are of poor quality. And then you want a standing lateral view that shows you the full profile of the spine, right from the femoral heads down to the C2 vertebra. So important thing to remember is flexibility x-rays are only for surgical planning, and you will not ask for bending x-rays as your first line of investigation. So I have seen many people saying that, okay, after the examination is over, students are saying that, okay, I'll ask for standing AP and lateral views, and I'll ask for bending views. So that's a wrong thing to say, because you will do bending films only if you are sure that you are planning for some kind of treatment. And there are two kinds of flexibility assessments that you can do. If you have a curve that is very large on your standing x-ray, say more than 60 degrees or 70 degrees, then a better investigation is a traction x-ray. Whereas if it's a smaller curve, which is usually what the typical adolescent idiopathic curves are, then you are asking for bending x-rays. So this example demonstrates that. So this is a 53-degree adolescent idiopathic curve. If you do a traction x-ray, this curve changes to 30 degrees. But if you do a bending x-ray, the same curve changes to 10 degrees. So you can see that in smaller curves, bending x-rays are more effective in correcting the curve. Whereas in larger curves, the bending x-rays are not very useful, because the rib touches the pelvis and prevents the spine from bending further. So you want to do a suspension x-ray. So this is how you do bending films. Bending films are always done supine. They are not done in the standing position. So it's a very important thing to remember. The reason why they are not done in standing position, because these are maximum effort by the patient to bend on one side. In a standing position, you cannot have maximum effort to bend on one side, because the child may fear that she's going to fall off to one side. So to take out that fear of falling on one side, you want to position the patient in supine position, and ask the child to have a maximum effort to bend on either side, left, right thoracic bending and left lumbar bending for a typical AIS patient. So remember, they are supine side bending films, and traction films are done this way, with a head halter attached to the neck of the patient, and someone pulling on the legs and then giving traction while you're taking an AP view. So the terminology quickly to go through: apical vertebra is the vertebra that is the most rotated vertebra, and the most translated vertebra, means the one which is maximum out of line is the apical vertebra, which is the T9 vertebra. End vertebrae are the vertebra that are at the ends of the curve that are maximally tilted. So you can see this, and this is the end vertebra that is maximally tilted into the concavity of the curve. Neutral vertebra is a vertebra that has the spinous process in the midline, and the pedicles equally visible on both sides. So you can see that this T11 vertebra is the neutral vertebra, where you can see both the pedicles symmetrical on either side. So it's neutrally rotated vertebra is called a neutral vertebra. Central sacral vertical line is a line that is drawn from the middle of the sacrum vertical. So that is central sacral vertical line. And a vertebra that is most closely bisected by the central sacral vertebral line is called the stable vertebra. So the L2 vertebra appears to be the most closely bisected by the central sacral vertical line. So the L2 vertebra becomes the stable vertebra. So in this patient, the D12 is the end vertebra. This one is the neutral vertebra. Again, this one is the end vertebra, and this is the proximal thoracic curve. This is the main thoracic curve, and this is the lumbar part of the curve, right? So this is the terminology that you will use. Cobb angle, everybody knows how to draw or mark the vertebra, the end vertebra, and measure the Cobb angle. It's important in the bending films. You use the same vertebra that you have used on the standing X-ray to determine the flexibility. You cannot change the end vertebra on the bending films. And you can also see the shoulder level by looking where the acromion is, pelvic obliquity by looking at where the highest point of iliac crest is. On the lateral X-ray, you can see the thoracic kyphosis, lumbar lordosis. In AIS, usually the thoracic part of the lateral view is hypokyphotic, as you can see in this patient. The normal kyphosis is reduced. Sagittal vertical axis is defined as a vertical line dropped from C7 straight down. So if you have a line that is dropped from C7 straight down, it typically falls within 5 centimeter of the posterior superior corner of the S1 superior end plate. So if you draw a line from C7, it falls somewhere behind the femoral heads, somewhere near the S1 end plate, posterior corner. So structural curve is defined as a curve that does not correct fully. If there is some residual curve that is remaining on bending films or traction films, that's called as a structural curve. Whereas a non-structural curve is a curve that corrects or overcorrects on the opposite side. So by the Lenke classification, we know that the structurality is defined by the 25-degree rule. And this 25-degree rule is a little arbitrary rule that is useful for planning the surgery, but it is not the true definition of a structural curve. In this patient, both the curves are structural. This thoracic and lumbar curve, both curves are structural, because you can see on bending film, thoracic corrects to 17 degrees and the lumbar corrects to 7 degrees. So they have some amount of structurality on both sides. Major curve is the largest curve, is called the major curve. The smaller curves on the side are called minor curves. In a S-shaped curve pattern, you have two major curves. So there is one major curve thoracic and the second major curve that is lumbar. Primary curve is a curve that is first to appear, but sometimes it is very difficult to identify which is the primary and secondary. You can see this child, when the child was 3-year-old, has had such a spine, and when the same child was 12-year-old, this is what happened to the congenital scoliosis. So in this congenital scoliosis, if you are seeing at 12 years, you wouldn't know whether this is the primary curve or this is the primary curve, because the secondary curve here is larger than the primary curve. You will need a very old x-ray to know how the curve started. So here this is the primary curve because this is the congenital part of the deformity, and because this congenital deformity progressed from 38° to 98°, the compensatory curve went from such a small curve to 102° curve. So the primary curve is the one that is first to appear, but for to define some curve as primary, you need serial x-rays to know how which curve started first. A full curve is a curve that has both the end vertebrae within the spine, whereas a fractional curve is this kind of a curve where you have one end vertebra here, and the curve is kind of ending because there are no further vertebra down below, because now there is pelvis here. So that's called the fractional curve. And lastly, the x-rays are also used to determine the Reiser sign and the triradiate cartilage. The Reiser sign is the iliac apophysis, and it progresses like this, and the iliac crest is divided into 4 quadrants. No apophysis seen is Reiser 0. Then the first 25% seen is Reiser 1. And if you remember, Reiser 1 corresponds to menarche in girls and onset of axillary hair in boys, which also means that by the time Reiser sign is visible on the pelvis, the peak height velocity or the peak of the growth is already in the past. From Reiser 1, the child has another 2 more years to grow, although the growth is slowing down, which also means that the rate at which the curve is going to progress is also going to slow down. By the time you are the child has Reiser 3, there is probably another more year of growth left, or maybe say 2 centimeters of sitting height remaining. By the time you have Reiser 4 like this, you have no more growth left, probably less than 1 centimeter of sitting height remaining, and not much change is going to happen after Reiser 4. So important Reisers for future progression of the deformity are Reiser 0 and Reiser 1. By the time it is Reiser 3 and 4, the child has more or less stopped growing and the deformity is not going to progress further. This is what typically happens in adolescent idiopathic scoliosis. So the other aspect you want to know is the triradiate cartilage. The triradiate cartilage, because this is Reiser 3, 4, the triradiate cartilage is closed, because if you remember, triradiate cartilage closes on the upslope of the curve, halfway point. So that is going to happen when the child is going to be Reiser 0. So when the child is Reiser 0 in the upslope of the growth curve of puberty, you are going to have the closure of the triradiate cartilage, which also means that if the triradiate cartilage is open, most of the pubertal growth spurt is remaining for the child, and the chances of progression of the deformity are quite high. And these are the indications for doing further imaging, which is typically an MRI. An MRI is done if you suspect a non-idiopathic cause of scoliosis, and you will presume a non-idiopathic curve if you have an abnormal neurological examination like asymmetric abdominal reflexes or foot drop or a cavus foot or a claw toes, hammer toes, or spasticity and brisk reflexes, or if the patient has back pain that is at rest, unusual kind of pain, not relieved on analgesics, and it's not just the usual typical kind of back pain that many children have. If the growth spurt is progression of the curve is very rapid, if there is thoracic hyperkyphosis, because normally AIS is hypokyphotic. If the thoracic spine is in hyperkyphosis, then that's not a usual idiopathic pattern. If there are abnormal curve pattern, which means instead of being a right-sided curve, it is left-sided thoracic curve. If there are double thoracic curves, if there are triple curves, or if there is a long thoracic curve, which is ending below T12, again, these are all abnormal or rarer curve patterns which need an MRI. Again, if it's a male child, then it is more likely to be non-idiopathic, because we know that idiopathic scoliosis, at least the severe ones, are more common in, or the larger ones are more common in girls. So the way it is that the incidence of idiopathic scoliosis in males and females, if it is less than 10 degrees, or between 10 and 15 degrees, is probably the same. Only the curves magnitude, as it becomes larger, the difference becomes more and more. So a patient presenting with more than 30-40 degree of scoliosis is 7 times more likely to be a girl than a boy, which also means that if you have a 40-50 degree curve in a male child, which looks very idiopathic, then you want to be careful in labeling it idiopathic, and you want to get an MRI done, because not always they are idiopathic. As we discussed right at the beginning, curves that have a juvenile onset, less than 10 years of age, also require an MRI. So that is it. That is my last slide. And the lecture notes for this talk are available on this website. You can download this presentation, and each slide has an explanation which you can go through at a later date. Is very similar to what we did during our last talk. So you can take a photograph of this slide, or use this QR code to go on this site to download the presentation and the presenter's notes. So with that, I thank you for your patient listening, and we can take questions now.
Thank you, Kshitij. Fantastic and a very, very comprehensive presentation. I think it covers the entire scoliosis. Thank you for that. A few questions. Now, Kshitij, during examination in a patient with scoliosis, you need to measure something called a costo-crestal distance, isn't it? So you need to measure that for the exam?
Not necessary.
Okay.
So so what I tell students is that what I don't do in clinical practice is not what is expected out of you in the exam. In exam, we expect what you see your faculty members and all your professors and all doing in real life. What is done in real life, what measurements are done in real life, are the measurements you are going to do in exam. So the real life measurements, most important, are going to be the height of the patient. It is going to be the arm span of the patient if you are suspecting that kind of a deformity. It is going to be the plumb line measurements, especially if the C7 plumb line is falling off to one side, or the midpoint of the thoracic cage is falling on one side, how many centimeter it falls on one side. So that's one important measure. And the last measurement that is extremely important is the scoliometer reading. But again, I think in the exam, you don't want to act smart and take a scoliometer with you, because I think the examiners don't expect you to carry a scoliometer, because a lot of spine surgeons also don't have scoliometers with them when they're doing an exam. But it is very important to have a scoliometer reading for a couple of reasons. First reason is that in some double curves, it decides the management. Means whether you are going to fuse the lumbar curve also with the thoracic. One of the decision maker for non-selective fusion versus selective thoracic fusion is the scoliometer reading. Because scoliometer reading is one of the most reliable measurement of rotation of the vertebra, whereas X-ray measurement of rotation is very, very inaccurate. The X-ray measurement of rotation is the Nash and Moore rotation index. It has a very poor inter-observer reliability. It was initially Lenke tried to include the rotation into his classification, but then they found that it is so unreliable, then they excluded that modifier. So what they rely is the rotation. So the Lenke classification is a 2D classification. It takes the AP and the lateral view, but there is no rotational component in the Lenke classification. Not for the want of trying. He tried to include it, but it was so unreliable. And that's why the importance of clinical examination, and that rotations are important to quantify, like the way you are quantifying Cobb angle. So that is one reason for measuring Cobb. And the second reason of measuring the rib prominence is that if you are doing surgery, that's what you are correcting. The child is not bothered with your Cobb correction, or the parents are not bothered with your Cobb correction. They are bothered about that rib prominence, because that's what brings them to you. So you can really make a pre-op, post-op assessment to the degree with which you have derotated the spine and corrected. So these are the important 4 or 5 measurements that are important in a deformity exam. All other measurements, like measuring the distance of the arm from the side, the costochondral distance, all those are just a way of measuring the asymmetry of the back. That is all, but it's not very a useful measure. Limb length discrepancy is an important measurement, especially if the pelvis is oblique.
And so if you want to describe what the Adams forward bending test does, so can you say that it helps in detection of early scoliosis? Can we say that?
Yes.
That's it, right?
It is, yes. So Adams forward bending test was used in United States, or it is still being used in some states in United States for school screening. So for girls it is done twice during their school years. For boys it is done once during their school years, and a nurse typically does the Adams forward bending test. And in an Adams forward bending test, what happens is that when you flex the spine, you are shortening the anterior column. So if you have a curvature in the spine, and if you are shortening the anterior column, the spine buckles further and rotates out to accommodate that extra length, because you can't shorten the spine without fracturing the vertebra. It's like a chain, it is going to buckle out. So it buckles out, and that's why the rotation becomes prominent. So approximately for every 7 degrees of axial rotation corresponds to 20 degrees of Cobb. So if your scoliometer reading is about 7 degrees, then it approximately corresponds to 20 degrees of Cobb angle, which is not always true, because some scoliosis may have more rotation than Cobb, and some scoliosis may have less rotation and more Cobb deformity or a lateral angulation. And that's the reason why the school screening programs are not all have taken off, because there is a lot of false positivity in it. And you can have an asymmetry of the back without associated scoliosis. That means your scoliometer readings are abnormal and there is no scoliosis. So that's why the thresholds to establish what determines a referral for an X-ray are kind of tricky to determine. A kind of an obese child, that 7 degrees is a little bit too less. Maybe 10-degree cutoff may be better for a little obese child or an overweight child. So we will be right in saying that Adams forward bending test is a screening test, and it has been used in United States in school screening programs to detect early scoliosis. But the reason why we are doing it in an exam for a patient with an established scoliosis is to assess the rotational component of the deformity. It is not to differentiate structural from functional curves.
Thank you, Kshitij, for that. The other question is, what is the role for a lateral bending film? You mentioned about supine bending film. Do you take a lateral bending films for your patients prior to surgery?
No, so the lateral bending film is not useful. If you want to know the correctability of the spine on an X-ray on the sagittal profile, you will do what is called as a fulcrum bending view. So if you have a kyphosis, then you make the patient lie supine on a bolster, and that bolster is at the apex of the kyphosis, and let the upper and the lower part of the spine fall downwards, and then take a shoot through lateral. So that is called as a fulcrum bending X-ray. So It's not a lateral bending X-ray, it's a fulcrum bending X-ray. And the same thing you can do it for the AP view as well. Make the patient lie on the side with a fulcrum on the convexity, means the convexity has to be lower, concavity has to be above, fulcrum in between, and the sides fall down. So that's a fulcrum bending view. So a fulcrum bending view is probably better than the supine bending views to assess the flexibility.
So do you do it before your surgical cases, the fulcrum bending?
Yes.
You do it, right?
Yes. So for an adolescent idiopathic scoliosis, you don't need to do a lateral fulcrum bending X-ray, because adolescent idiopathic scoliosis don't have an abnormality, a hyperkyphotic abnormality. So you would do a fulcrum bending lateral X-ray in Schurman's kyphosis. You might do it in patients with neurofibromatosis who presents with kyphoscoliosis. You know, they have a kyphotic component to the scoliosis. So one thing which I have noticed is
regular
for
adolescent
a regular, no, not needed.
lateral bending AP view. I mean, the patient is on the side and getting an AP view over the fulcrum.
That is called a fulcrum bending AP view.
Yeah. So do you get that? Do you get that for your
Yes, yes. So you get only one, either get supine side bendings or you get fulcrum bending view. But it's not called lateral bending.
Yeah,
it's
yeah,
called
I got
a fulcrum
it. I got it. Because it's not typically a lateral X-ray. It's just a position of the patient that's important.
Correct. That's called a fulcrum bending view.
And do you think that is a better view when you're planning surgery compared to a supine one?
For AIS patients, the typical AIS patients, probably yes. But it's not always mandatory. Now there are different schools of thought. Now the guys from Hong Kong who propose the fulcrum bending views will get fulcrum bending views, whereas in United States we used to get supine side bending views. Both are fine for the typical curve patterns, which is the AIS curve patterns. But I personally feel that fulcrum bending view gives a better assessment for those moderate curves. The very severe curves is the traction X-ray.
Okay, Kshitij. I think that's all the questions that we have. Kshitij, thank you for a fantastic session. It covers the entire session on scoliosis. Thank you for giving 2 fantastic lectures. And already your first lecture is viewed so many times and shared across all over the world. Thank you very much for joining in, Kshitij.
Thank you very much.
Yeah.